The eustachian tube can't open itself. Something has to open it. And that something is bolted to the bone that you adjust. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. Good morning, subluxation slayers. So, like any good nerd, I saw that Anatomy Trains recently was doing a live on Zoom and recorded dissection on head and neck anatomy. And so, of course, I had to get it and watch it and spend some team trainings around it. And it was pretty cool. I thought that there was going to get some more out of it. They spent a lot of time on structures that I don't care as much about. But hey, like whatever, that's fine. That being said, it was awesome. It was really cool to see. And there were some really, really, really cool takeaways that I had that I really just wanted to talk to you about. So one of the things that I noticed as we were going through this direct dissection that just stopped me in our tracks was the anatomy of the Tensor Palatini, the eustachian tube, and the pterygoid muscles and how they attach to the pterygoid plates, and how it was all packed into the space that would cover like less than a fingertip, millimeters. And the muscle that opens the tube grabs right onto the tube itself. Like, we have talked about this for years. We've drawn it on whiteboards, right? We've talked about how, well, like C1 and the upper cervical and the temporal bone and the eustachian tube, like, of course, that all is really important. But to actually see how the tube is being enveloped, especially when doing cranial work, on top of chiropractic, right? In the structures that we influence and make change with every single day is just like of course, this stuff works, right? It applies to so many of our cases. It applies to any kid with a narrow palate. It applies to anybody with sleeping issues, anybody with tinnitus, anybody with vertigo. Like, it all comes together. So let's kind of go into the overarching story. The eustachian tube, of course, is something that everybody blames when it comes to something like an ear infection. The fluid won't drain or the ears won't equalize. The kid keeps getting infections. The adult keeps hearing the ringing. And of course, they want to go like put in tubes or anything else like that. But the tube is not a muscle. Of course, it can't open itself. It just sits there passively and waits for something to open it. And that something is the muscle that lives attached to the sphenoid, which is what I hope that you are already addressing. So the whole question is this. If the tube can't open it itself, and the muscle that opens it lives on the bone where we work, then why is nobody in the entire chain of people who manage these challenges actually looking at that bone? So that's the episode, right? It's not cranial work helps ear infections. What we're going to talk about is the mechanism, what opens the tube, what shuts it down, and why we are positioned to change it in a way that nobody else can. Welcome to the Cranial Doc. Let's have fun. So, eustachian tube itself, it runs from the middle ear down to the back of throat, the nasopharynx. It has two jobs. Number one, it ventilates the middle ear and keeps the pressure behind the eardrum equal to the pressure outside. That pressure gradient is massively important. And number two is it drains. Whatever the fluid in the middle ear makes or has, the tube carries it down and out. When it's working, you never think about it. If you swallow on an airplane, your ears pop and you're done. When it stops working, everything backs up. Pressure builds, the fluid sits, the warm pool of fluid trapped behind the eardrum is exactly where ear infections start. I had a friend of mine growing up that had a creek of just standing water next to his house, and there was always mosquitoes, and it always smelled like shit. And that is because just bacteria, everything else like that could grow in it because the water was not moving, was not running, and it was stagnant. It always smelled so bad. And this guy was, I mean, they lived in like a multi-million-dollar house, and it was just that corner of their property smelled like shit all the time. And that's literally what we get to work with all the time. So anyway, that's how infections start. So the eustachian tube is closed by default. Its resting state is shut. This is what most people miss. It's not just a pipe that's open until something claws it. It is a collapsed closed structure that needs to be actively pulled open. It's made of a bony part near the ear and cartilage near the throat. That cartilage part is the working end, and it stays closed at rest to protect the middle ear from sound and from junk that's coming up from the throat. So opening the tube is an active event. Every opening is a muscle firing, and if it doesn't fire well, or the tissue around it is loaded and restricted, the tube won't open well. And a tube that doesn't open well is a middle ear that cannot ventilate or drain. In kids, we know this is made worse for a mechanical reason. The tube is shorter and much more horizontal than in adults. An adult's tube runs downhill, so gravity helps it drain. A young child's runs nearly flat. There's less drainage help, more backup, which is part of why ear infections and childhood problem are something that a lot of people grow out of and, of course, into something else. And then also with that, we know cranial motion is much larger in children because there's less fusion in the cranium itself. So they do have added help. It should have added help. It's just not gravity. So before we even get further into the muscle, let's sit with this. Every recurring ear infection that you have ever seen is a tube that isn't opening enough. The fluid is, of course, the symptom. We know this. The failure to open is the cause of that. Well, let's continue to explore that. Let's talk about the kid on our table. He has a flat, or she has a flat horizontal tube, and it won't open on top of it. That's 2 out of 3 strikes before anyone's ever touched him. Everyone is downstream is managing the fluid, putting in the artificial irrigation system, namely tubes, giving antibiotics to treat the infection, instead of asking, why is this child's not open? If we're designed perfectly, that means that horizontal tubes in a child is perfect. It's not a problem, it is perfect. It is supposed to be that way. Why is it not working right? That's the question that we should be asking. So, and this is the difference between what's the difference between common and normal, right? So we know that there is one main muscle whose job is to open that tube. It's called the Tensor Veli Palatini, the tensor of the soft palate. Every single time that you swallow, every time that you yawn, that muscle fires and pulls the tube open. That's the pop you feel on the airplane, the regulation. It sits up on the roof of the mouth region off to the side, right in the pterygoid area of the sphenoid. Now, watch how this muscle is built because it's one of the most elegant setups in the whole head, and it's the whole reason we are having this conversation on the Cranial Doc podcast. The Tensor Veli Palatini starts up high. It originates from a fossa and the spine of the sphenoid, and here's the key, it also originates from the cartilage wall of the eustachian tube itself. It is literally anchored to the tube it is meant to open. From there, it runs down as a muscle, becomes a tendon, and that tendon wraps around the hook of the bone at the bottom of the medial pterygoid plate called the hamulus. The hamulus works like a pulley. The tendon almost turns 90 degrees around it and then fans out horizontally into the soft palate. So when the muscle contracts, it pulls on the palate, and because part of it is woven into the wall of the tube, it pulls the tube open at the same time. One contraction with 2 jobs. It tenses the palate and opens the tube. Every structure in the entirety of that chain is cranial. The origin is on the sphenoid. The pulley is the hamulus, which is the sphenoid. It fans into the palate, which is going to involve the maxilla and palatine. Even going through the ear is the temporal bone. If any of these are loaded, torqued, or restricted, we are changing the mechanical environment of the muscle that should open the ear. So think about that as a clinician, right? The muscle that opens the ear originates at the sphenoid, goes to the tube, which is located in temporal bone. It pivots on the sphenoid and inserts into the palate. There's not a single part of that that isn't in the wheelhouse of what we check and adjust on every single patient. So this is why we can't at all separate the palate from the ear. And this is why when you show me a child with chronic ear infections, I am going to show you a child with a sphenoid and maxillary subluxation pattern that is leading to a compressed and narrow palate every single time. When we can free up the compressed palate and unlevel and untorque and unflex the sphenoid, we are changing the tension on the tensor veli palatini and the hamulus it pulls against. By the way, when I just riffed and said unflex the sphenoid, typically if you have a narrow maxilla, we're going to see the sphenoid struggles to move into flexion. So I was talking about lateral flexion of the sphenoid, and I just cut off lateral. So if you're like really anal and analytical there, and you were like, he didn't say that right, I made a mistake when speaking. So it's usually stuck in extension, has trouble going to flexion, but it will be torqued and laterally flexed. Sorry to go on that rabbit hole there. Just making sure that you are paying attention. So anyway, the kid with that high narrow palate and the recurring ear infection is not a coincidence. It is one mechanical story. It is the same compression that narrowed the palate is loading the muscle that is supposed to open the ear. So here's where it jumps from ear infections to tinnitus or ringing in the ear, because that's really how this thing is wired. There's a second tiny muscle, this one inside the middle ear, called the tensor tympani. Its job is to tense the eardrum and dampen loud sound and protect the ear. The tensor veli palatini opens the tube, and the tensor tympani inside the ear shares the exact same nerve supply. They're both innervated by a branch off of the mandibular division of the trigeminal nerve, two different tensor muscles with one nerve. So think about what that means. The nervous system is running the muscle that opens the tube and muscle that tenses the eardrum off of the same line. They are neurologically coupled. When that system is dysregulated, we don't just get a tube that won't open, we get a tensor tympani that also won't settle. That spasm is a recognized cause in the literature of tinnitus, specifically of arrhythmic or clicking tinnitus, and it is tied to that same trigeminal wiring. Now let's zoom out one more level. All of this lives in the territory of the trigeminal nerve, which is the nerve that is central to so much of what we see in cranial work, in headaches, in jaw work, in facial pain. The ear is not on its own little island. It's not just in the temporal. It's not off to the side. It is plugged into the trigeminal system that we've talked about on this podcast so many times. So the adult who comes into you with ringing and ear fullness and a normal hearing test and a shrug from their doctor, you have a mechanism for them. You don't have a promise. You have a mechanism. We want to evaluate trigeminal dysregulation, a tensor system that won't come down, tube and palate tension that nobody has looked at. That is the patient who is in your office who has gone everywhere and gotten nowhere, because everywhere they went was looking at the ear itself, not at the system that was driving it. So there's another neighbor that, of course, we have to talk about also, because it ties into the cases that we're already taking care of, and it sits to the lateral to the pterygoid and connects straight to the jaw joint, okay? There's a lateral pterygoid that is attaching into the TMJ disc, another primary player in how the jaw moves and how the disc tracks. So the TMJ, which again is a huge part of what we work with, has attached muscles that control chewing and a muscle that opens the ear, and they are all crammed into the same few millimeters hanging off of the sphenoid. In fact, when I watched the head and neck dissection, it was like the pterygoid muscles were almost like enveloping, in this case, the actual eustachian tube itself. So the pterygoid muscles, medial and lateral, are the deep muscles of mastication and chewing, and they sit on or around the pterygoid plates of the sphenoid right alongside our favorite tensor veli palatini. Sharing that real estate means that we have to share the mechanics. A jaw that deviates, or a disc that tracks poorly, or a chronic clench, which we know all of those go together, but each one of them by themselves, and especially all together, changes the tone and position of the tissue of the pterygoid region, of course. That same region that the tube opener is working in. So that's one of the reasons why TMJ patients so often also have ear symptoms, fullness, ringing, and the sensation of a clogged ear that no ENT can explain. In fact, I learned about this because we started getting referrals from ENTs who I had never met, who said that the patient's tinnitus was a jaw issue and not an ear issue. So this is out there, right? So if you're already working on the TMJ, you are already in the room where the ear lives. You just maybe didn't know that you were there. And always as a fun reminder, the T of TMJ joint stands for temporal, which is where the ear is located. The TMJ patient with the clogged feeling ear is just a preview of everything that we covered. Same nerve, same system. So we've got the mechanism on the table. So what do we do about it? Well, we approach this the exact same way that we approach anything else, right? Bottom up, back to front, inside out. That's the way that we approach this. So I'm not just jumping right to the TMJ. I'm not just jumping right to the cranials. I'm thinking about my order. I'm making sure that the occiput, the occipital joint are clear. I'm looking at the sphenoid, making sure the sphenoid-basilar is moving appropriately, and looking for contact points like the pterygoid and sphenomaxillary to make sure that those are moving appropriately as well. I'm assessing category 1 versus category 2 and making a decision of whether or not the temporal needs to be addressed. I am also looking at the tracking of the jaw itself and saying, is this a primary temporal TMJ issue, or is this more of a functional issue like a frontal or a sphenoid? I am looking at all of that, addressing the disc, looking to make sure that motion is moving appropriately and that there are no torquing compensation mechanisms that are happening. I'm not seeing them for 1 or 2 visits. I am looking at doing a corrective phase of care because a lot of the cranial subluxation patterns that we see, especially in adults, that are caused and locked in because of the compensation, chicken or the egg, doesn't matter which one, of the spine. And if we are continuing to have spinal subluxation patterns, they will continue to cause and drive the feedback loop that causes the cranial subluxation pattern. If we don't address an anterior head posture or reverse curve, and then we will not help the TMJ go back into the right direction because it will continue to compensate 100% of the time. That's the exact way that we work with this. Giving to you just really quickly because I want you to either say, wow, I've got that down, or feel the gap. Because if you feel the gap, I want you to study with me. I want you to go to thecranialdoc.com/training, and I want you to sign up for our level 1, level 2 Foundations of Cranial Adjusting course so that you know how to correct this and work with this. There is a huge difference in my book between a chiropractor who does some cranial work and a chiropractor who is a craniopath, who is a specialist, who does this work and gets paid appropriately for it. And I want you to be the latter if you are up for it. It's hard work, but I'm going to go walk you through the process. So let's be really dead clear, okay? Say it out loud. We do not cure tinnitus. We do not promise that a kid will never get an ear infection, okay? What we do is restore appropriate motion and tone through the cranium, through the sphenoid, through the palate, through the pterygoid region so that the tube can do its job. It can drain, it can ventilate, it can equalize. Now, vertigo, because often people will lump this in, the stuffy, full-headed pressure of dizziness, the room spinning, everything else like that. There is a mechanism that we do affect, and we can work really amazingly with vertigo patients. However, it is running a bit in a different system in the inner ear than this one. So if you're working with other providers, okay, or having a conversation with somebody who really knows their stuff, don't lump vertigo in with this same conversation, which is really interesting because when we look at, and one, like, I can't help every tinnitus case, of course. I can't help every ear infection case, of course. And I can't help every vertigo case. But when I see Meniere's disease, which is those different pieces coming together, it's like, yes, those are the ones we can actually get the most help with, but it's for a different reason, which maybe we should do on a different podcast. But anywho, make sure that you really do understand this because, if you're listening to this, your job is to become the authoritative source. You don't have to fudge or fabricate or do anything with the information you have because you just happen to know it. You are the best. And you can just present this, say, this is factually what it is. This is what I can do. This is what I can't. And that is the thing that makes me not just be good, but be great because we can be the most trustworthy person in the room because we don't have to fill in any gap because we just know our shit. So, long story short, this is what I want you to walk away with. The eustachian tube can't open itself. Something has to open it. And that something is bolted to the bone that you adjust. So, let's restate the through line one more time cleanly. The tube is passive. The tensor veli palatini opens it. It lives on the sphenoid, pivots on the hamulus, fans into the palate. It shares a nerve with the muscle inside the ear. And the jaw's right next door. Once you've seen that, the sphenoid and palate work stops being optional in these cases, and it becomes the reason that you can help this person that nobody else could. Most chiropractors will go an entire career and never put this together. The ones that do end up being the office that the pediatrician and ENT send their hardest cases to, even if they actually don't know the referring provider, which still is just mind-blowing to me every single day. They're the ones working the thing that's actually broken instead of chasing fluid every single visit. So again, if you want to learn how to actually feel and work this region with your own hands, that is the point. Get on the email list at thecranialdoc.com and of course, go to where I just said, thecranialdoc.com/training, and sign up for Foundations of Cranial Adjusting. Go find the hamulus, go slay some subluxations. I'll see you on the next one. Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.